So, very pleased to welcome on and introduce Seth Carroll. Now, Seth is the PGY2 emergency medicine pharmacy resident at Freighter Hospital in Milwaukee, Wisconsin. Seth is on Twitter or X at Seth C Farm D. Seth, welcome. How are you doing today?
Doing well. Thanks so much for having me.
The thanks is all mine. Now, if the listeners have been on the podcast, they know I kind of have like a little like form people fill out. Fun facts is a part of it. And Seth may have filled out the most interesting fun fact of them all, and it involves a Rubik's Cube. So, Seth, number one, tell the listeners what your accomplishment is, and then give us a little bit like how do you I've always wondered this, like, do you just like practice and grind it out? Are you just good at it from the start? How does this all happen?
Yeah, so I can solve a standard Rubik's Cube in about 30 seconds or so. And it started back in seventh grade over summer. I needed something to do as like a hobby. And so I watched a series of YouTube videos that just kind of walked you through how to solve your very first Rubik's Cube. And from there, it kind of spiraled this whole fascination with them. And I got slowly learned different algorithms and got faster and faster at solving them as time kind of went on.
Off the top of your head, how many different ways could you use to solve it? Because you said different, and I didn't compute that there would be multiple different ways you could do it.
Yeah, there's a lot of different algorithms out there. I know probably maybe six or seven or so algorithms. And so I use kind of all of them interchangeably to solve a Rubik's Cube.
It makes sense, not only being an EM pharmacist, but almost every person that loves toxicology that I've met is one of the smartest people that I've encountered. And if somebody that can solve a Rubik's Cube in under a minute falls in that category. So um, rarely do we get to cite not one, but two New England Journal of Medicine studies when discussing toxicology topics. But this emergency medicine clinical pearl highlights the antidote with a name just as great as its clinical efficacy. So, Seth, the floor is yours.
All right, thanks again. So today I want to take a deeper dive into fomepizole. But before we get started, I want you all to picture this. You're a healthcare worker and overhear that a patient is coming to the hospital after a self-harm attempt. They reportedly drank antifreeze, and while en route with EMS, they are somnolent but otherwise have normal vital signs. In the emergency department, their electrolytes appear normal except for a low bicarb and are found to have a pH of 7.3 with an osmolar gap of 26. The decision is made to treat for an ethylene glycol exposure, and IV ethanol is ordered. Now, wait a minute. The year's 2024, and admittedly, I have never even seen an IV ethanol order. But before fomepizole was approved by the FDA in 1997, which happens to be the year I was born, that was the standard of care for ethylene glycol poisonings. The goal was to reach a serum ethanol level between 100 and 125 milligrams per deciliter, which for me would take a little over 3 White Claws to reach. For comparison, the legal driving limit is about 80 milligrams per deciliter. And so we were effectively trying to keep our patients inebriated to manage the poisonings. But why? It sounds a little strange, but the parent toxic alcohol compounds really aren't all that toxic besides their inebriating effects. It's actually the metabolites that cause the majority of the toxicity. Take ethylene glycol, for example. It gets metabolized by alcohol dehydrogenase to a glycoaldehyde, which then it gets converted to glycolic acid through aldehyde dehydrogenase. From there, it gets further converted into a glyoxylic acid and then oxalic acid. And it's actually these acid compounds that contribute to the profound metabolic acidosis that occurs. And unique to ethylene glycol exposures is the oxalate actually will precipitate with calcium to form crystals that end up causing tissue damage, most notably found in the kidneys with renal tubular necrosis. So why do we use ethanol? Well, first and foremost, it's readily available and has a higher affinity for alcohol dehydrogenase, preventing those toxic metabolites from being made. But that's not to say that ethanol doesn't have some complications. It carries risk of hepatotoxicity, hypoglycemia, CNS depression, and I mean, come on, we all know some people who can be a little difficult to work with when drinking. Lucky for us, fomepizole, otherwise known as 4-methylpyrazole, serves the same function as ethanol. Fomepizole is a competitive inhibitor of alcohol dehydrogenase. So just like ethanol, it too prevents the metabolism into those toxic metabolites. But the next question I'm sure a lot of people as healthcare workers would have is at what cost? And to all the pharmacists out there thinking of the actual dollar amount, fomepizole is rather expensive. But figuratively, fomepizole has few side effects. There is no central nervous system depression, a longer duration of action, and very predictable pharmacokinetics. This allows for a standardized dosing regimen without the need for frequent blood level monitoring, all things that ethanol does not have. And fomepizole does carry 2 FDA indications as an antidote for both ethylene glycol and methanol poisonings. And the 2 landmark trials that were both published in the New England Journal of Medicine were done by the methylpyrazole for toxic alcohol study group, led by Dr. Jeffrey Brent and published in the New England Journal of Medicine. They are very similar studies, but evaluate fomepizole for the treatment of ethylene glycol poisoning, followed by evaluating its use in methanol poisonings. Now, in these studies, fomepizole isn't compared to IV ethanol. And the papers very rationally explain that given the rarity of the exposure at the time, it was not feasible to recruit hundreds of patients. And in the world of toxicology, pretty unethical to compare to placebo. Now, unfortunately, toxic alcohol poisonings isn't as clear cut as it may seem. Toxic alcohol levels are send out labs and usually not available readily enough to aid in the decision to treat with fomepizole. This often forces clinicians to empirically start fomepizole based on presentation, history, and more rapid serial lab tests that show a declining osmolar gap with a widening anion gap metabolic acidemia. And let me emphasize the need for serial lab tests, because a single time point showing an osmolar gap, like in our case at the beginning of this talk, doesn't necessarily mean that there was a toxic alcohol exposure. And this is because people have varying degrees of a baseline osmolar gap. And oftentimes we don't know what that baseline osmolar gap is. And this adds to the problem because we also don't want to treat patients unnecessarily, in part because of cost. While fomepizole is a generic medication, it still costs over $1,000 per 1 gram vial. And a study by Leonard and colleagues characterizing fomepizole's use from 2010 to 2021 suggests that a rapid test for toxic alcohol actually has the potential to save a conservative $1.5 million every year by reducing fomepizole's use. And as pharmacists, it's an area that we play a vital role in the judicious use of medications. It's essential to verify the indication for treatment, evaluate labs like ethanol levels, and especially since administering fomepizole may be unnecessary if ethanol was co-ingested, these are all areas that pharmacists can assist with. Additionally, we can help dose the medication, monitor renal function, and ultimately stay informed about any sort of plans for renal replacement therapy, which also impacts dosing. It's important to note that fomepizole has also faced drug shortages in the past and could very likely again in the future. So ensuring its appropriate use and maintaining adequate drug supply in the hospital and fostering communication among central pharmacy and the providers are, including poison centers, are all critical areas where pharmacists can make a significant impact. Now, what kind of pharmacist would I be if I didn't provide dosing recommendations? The package insert says to load with 15 mg per kg, followed by 10 mg per kg every 12 hours for 4 total doses. At that point, fomepizole is thought to induce its own metabolism, so the dose is then increased to 15 mg per kg every 12 hours. In patients receiving hemodialysis, it gets a little complicated, and that dosing interval decreases down to every 4 hours. And with CRT, a recent study suggests dosing every 8 hours. But before I go, what if our patient didn't ingest ethylene glycol? Does fomepizole potentially help with anything else? And to answer that question, yeah, there's a slew of things that it might be beneficial for. There's a case series about treating disulfiram ethanol reactions with fomepizole based on the same premise that it inhibits alcohol dehydrogenase. Then there's been a lot of literature out there discussing its role in acetaminophen overdoses, and even an ongoing clinical trial that may wrap up toward the end of 2025. There's two different hypothesized mechanisms for its use in acetaminophen toxicity. The first by inhibiting CYP2E1, which is responsible for oxidizing acetaminophen into the toxic metabolite NAPK. However, in patients who present later in their clinical course of acetaminophen poisoning, NAPK is already present, and which then causes J&K activation, leading to mitochondrial stress and ultimately hepatotoxicity. Fomepizole has been hypothesized to inhibit J&K activation and potentially help patients who present to healthcare facilities later on. Now, before everyone starts giving fomepizole to acetaminophen poisonings, let me be clear. It is not guideline recommended. The evidence for its use stems from in vitro data, animal studies, and some case reports. And while it's exciting to potentially have a new use for fomepizole, more evidence needs to come out. So we talked a lot about how toxic alcohol poisonings work and why fomepizole revolutionized the treatment for ethylene glycol toxicity and methanol toxicity. But please remember to contact your local poison center to not only help manage these toxicities, but also to track cases and potential threats to public health. They're available 24/7, 365 days a year at 1-800-222-1222.
No better way than to end with everyone's favorite toxicology number. That should be everyone should have a magnet on their fridge by now if you've been involved or anything with that. Um, an important follow-up question before we get into my real one. What White Claw flavors would the three have been in the intro for the patient case there?
It's a good question. Really, I like all of them, but I'm going to go with lime.
Okay. Yep. The There was only like one wrong answer, and I think that would be like watermelon maybe, but either way, okay. Now, a lot of the job openings, right, are things like evenings, overnight positions, and even for our EM pharmacist colleagues. So give us some tips and tricks on how we can ensure, um, the appropriate patients may get it, or tips about administration and just fomepizole in general. Give us some of those clinical pearls, I guess we'd refer to them as.
Yeah, absolutely. So when talking about those minimal side effects that fomepizole has, really the only thing to make note of is that you will see a transient bump in LFTs, and that's okay. They really don't go any further than that, and they self-resolve. So it's okay to recognize that that's going to happen. Some other administration things is it can cause some burning infusion reactions in the peripheral line, can cause some headaches, and then just some fun little pearls that I learned while looking into some of the literature behind fomepizole was that you can actually give fomepizole orally if IV access isn't available. There's a case study in healthy volunteers that looks at its bioavailability, does cite some pretty poor taste, and so they do recommend mixing it with vegetable juice, which is kind of fun. Um, and then interestingly, fomepizole can also solidify at cold temperatures. And so you can warm it up just in your hands or under some warm water in the vial still if it does become solid. And that can be some helpful tips and tricks to help administer fomepizole.
I love that. Odds that we got a V8 vegetable juice reference were really low heading into this clinical pearl, but this is awesome. And everyone mentioning you mentioned the shortage. Anyone that I dealt with it, and my love and respect for Fomepizole is through the roof, right? When you've actually tried to titrate alcohol, right, with its inducible kinetics and things, it's a disaster. So, Team Fomepizole for life. Please be judicious so we don't go on shortage. And these are some awesome tips and tricks. Everyone, reach out to Seth. Let him know what a great job this was at Seth C Farm D. But appreciate you passing on this emergency medicine and toxicology clinical pearl, my friend.
Yeah, thank you so much for having me again, Nick.